Good morning to all of you, and I'm really grateful to EBNEO for giving real importance to quality improvement, work which has to be done for neonatology. And I was so happy to see that there was a QI workshop, pre-conference workshop. There were a lot of quality improvement papers which have been shared. Even the best gold medal award here went to someone who did quality improvement work in the NICU. I'm going to share with you the Indian perspective. What we have learned in the last 3 years while we started doing a journey for quality improvement, and how we are trying to take it not only in India, but across the region. On the right side is on top is my teacher, mentor, Dr. Meherban Singh, who way back 3 decades ago published a study in our unit that by doing 3 simple interventions, we were able to reduce infection-related mortality by nearly 25%. It is published in 1989. And the 3 interventions which we implemented in the NICU at AIIMS were decreasing overcrowding in the NICU, unnecessary babies were not brought, lot of use of disposable items in the unit, not using stocked heparinide solution. These 3 simple interventions reduced the infection-related mortality by nearly 25%. At that point of time, we never knew this jargon of quality improvement and even quality of care, what it means to the babies which we were treating. And in the last 2 decades, many of you who are sitting in this hall have met these people who are shown here. One is Shu Lee, who is from Canada. He has visited India on many occasions, brought the EPIC model for doing quality improvement using evidence-based methodology, and wanted that India should take a lead and make a network for doing it. But due to some reasons, we were not able to walk that path. And on the right lower is my teacher, my spiritual guru, Jeff Gold from Stanford. And what he taught me was what Roger Saul was saying: Ashok, never teach your students to collect too much of data, too much of information on the processes which they are not going to put to use. So have small data which can be put to use, or processes which people can put to use after looking at that data. And in the center is a quality improvement movement which we started 3 years ago at All India Institute of Medical Sciences, across disciplines, not only neonatology, pediatrics, it is emergency department, trauma center, surgery department, and medicine department, surgical department. So we started a movement of quality improvement at AIIMS, New Delhi, with a team of nurses who are real leaders and champions for doing QI work, and then working very closely with consultant and resident doctors. So I'm going to focus today on what a neonatologist must know about quality of care and quality improvement. And my task is made very simple by Lakshmi with the previous presentation. And then share learnings in the large hospital and district hospital, how we have moved with doing quality improvement care implementation, and what are the challenges and what is the way forward for a country like India. You know, as teacher, we teach students. We give them the contents. We make them skillful by training them in skill labs, what Praveen mentioned, Daksh Lab. We teach them competency-based learning, and then they provide clinical care. Many times they are in the field for taking care of sick babies and mothers, directly providing the care. And then what happens is you have outcomes which are not real good outcomes according to real big standards which are in the Western country. So to me, it looks many of us need to embrace the new pedagogy for teaching learning. For our young postgraduate neonatal fellows, and this pedagogy is by using simulation technique before they actually start working on the patients. This simulation technique should not be on high fidelity models, which are very costly and the country cannot afford. So try to use local, low-cost models to teach people the pedagogy of simulation. Simulation is not models and mannequins and high-fidelity mannequins. It is a skill, learning for people by learning how communication skills can be better. They be developed, how debriefing has to be done, how to build psychomotor skill, how to work as a team while you are trying to provide care as a clinician. So simulation is much more than the models we have concept for learning skills. And these skills are very important for reducing medication errors, for bringing efficiency in the system, and making sure your patients get right treatment at right point of time. Way back, Institute of Medicine in 2001 gave the definition of quality of care. Patient is centric. You need to provide care which is safe care, efficient care with effectiveness, bring efficiency in the system while you are trying to provide care, and always remember the care for rich and poor has to be same. There has to be equity of care. World Health Organization realizing that in low middle income group countries, we are always faced with lack of manpower, resources, infrastructure, modified this definition of Institute of Medicine and came back in 2014, bringing into that the healthcare facility must be ready to provide quality care. So they bring readiness of healthcare facility in terms of infrastructure, which Murki was alluding to, that if you want to provide quality care. They also say for patients, especially a woman who is delivering, there must be privacy of care, respect of care, and confidentiality of care, which has to be inbuilt. By making this definition by World Health Organization, there is huge pressure on all the member countries who report to UN Assembly that they are committed to make these things happen in all the healthcare facilities in the country. We know saying is and making a policy is not going to translate into improving everything everywhere in the country, which is a diverse country like India. But having those pieces in the form of policy and guidelines which are there, which all of you should share with your partners and state governments, that these are what is going to be required if we are talking of providing quality of care. So the quality of healthcare is covered into two big pieces here as quality assurance piece, which is shown on the left side. And in that, I mentioned that there are national quality assurance standards which are laid by Government of India. You need to look at that first and try to use your NNF accreditation criteria also for anyone who is running the NICU. These are also endorsed by the ISQA, which is the International Quality Assurance Standards for India. The second piece, which is on the right, is quality improvement. This relates to frontline health worker. How do you change behavior, attitude in healthcare professionals who are frontline, so that the way they are performing can be changed by doing quality improvement methodology? And to do this, we know that Deorari gave long ago that there is a structure which is there, which is a health facility, and a process of care which you provide, which determines the outcome. And this is all contextual. To give you an example, to understand this in simple terms, you need running water supply and a soap and a wash basin to wash hands. So that is a structure. The process is you adhere to hand washing compliance in that particular hospital. And the outcome is the number of infections which will occur if you keep on tracking how is the hospital acquired infection rates. You know, we talk of that evidence-based medicine need to be practiced. We all want to do that, but it takes time for us that those evidence-based practices are translated at the ground by the doctors and nurses. India is a country which is very peculiar. We know wonderful evidence-based interventions which have to be in place. Who has stopped people from initiating breastfeeding during first 1 hour? UNICEF has been talking about this for last 2 or more than 2 decades. But at this point also, early initiation of breastfeeding occurs only in 1/3. Exclusive breastfeeding rates are pathetic, below, at 6 months of age, below 40%. Adoption of kangaroo mother care for eligible babies is again dismal. There are barriers and challenges there. How these have to be fixed? These have to be fixed by us. No one will come from outside to teach us how this has to be done. Here I give you an example of something which works wonderfully in tertiary care hospitals and in Western world, use of antenatal corticosteroids. And look at, while a study is done in 6 countries and implemented in community hospital, you have results which are totally different. Maybe there is fallacy in the way the study design was done or enrollment was done, but it showed increase in puerperal sepsis rate, increase in mortality, newborn mortality, while this was being used in community hospital. So something which is evidence-based, while you take to population, needs something else. This is what operational research or implementation science is going to address too. And we need to keep an eye on that while we take evidence-based interventions which work wonderful in the Western country for use of high technology. While we do it in our setting, our results may be totally different. So quality improvement benefits a neonatologist in many ways. As Lakshmi alluded to, it brings efficiency in healthcare, it reduces cost, it adds value. You learn, you reduce medication errors and improve patient safety. It teaches you principles of leadership, team building, putting data to use. Team building culture, leadership, and knowing skills of QI in a simple way is what will motivate you, that you can embed quality improvement in your culture, in your work, while you are working in your hospitals. And Roger Saul said, you need leadership, qualities, QI skill, and a culture if you have to do quality improvement, just prior to Lakshmi. Quality improvement gives you a lot of dividends as a neonatologist. You can do thesis, dissertation, you can do publications, you can attend meetings, international meetings. In my institution, we got this, that this is going to get to annual performance review of junior faculty members, what work they have done related to improvement in the department or in the division where they are working. So by doing that, what will happen is more and more people will start doing quality improvement. This again, a repetition of a slide which Roger Saul showed, that quality improvement, how it is different from research. And you know, for doing QI and research, you need quality assurance piece in place. Your infrastructure has to be there, manpower has to be there, your protocols have to be there, STPs have to be there, then only you can do good research or quality improvement. So quality improvement is, if you have an intent to improve current practice, it is instantaneously, it gives you, it is contextual. Many times you don't need IRB approval for this. It is ownership by the frontline workers. It is low cost. You can do it. And it is a continuous process. Your protocol for quality improvement can keep on changing with the PDSA cycles, which are small PDSA cycles. So your protocol is not like a randomized control trial, which is made once. Your results are going to be after 1 year or 2 years. You can't open up, you can't change the protocol. So the advantage of QI is the protocol can be changed. On the other hand, research is very costly, high cost. It needs IRB approval. And many times, as I shared with antenatal corticosteroids, it may not be generalizable result which is published by that study, which is the research study. To demystify quality improvement and to make it very simple for healthcare professionals to understand, AIMS WHOCC team, along with WHO CRO and US Aid Assist, came out with a 4-step model for improving and teaching skills of quality improvement to healthcare professionals. This package is made from the learnings we got from Institute of Health Improvement, from the Canadian model of the EPIC, and the US Aid Assist model of doing quality improvement, and the UK model of doing quality improvement. So it is a simplified version of 4-step approach. First is identifying the problem, prioritizing, making a team, and then making an aim statement, what Lakshmi said. Second is analyzing your data and measuring how quality, what are the things you will like to address to by using 4 tools, which are simple tools, by getting to the root cause. Looking at the process flow, looking at the fishbone, asking 5 why questions, or doing a Pareto chart analysis. So for Dr. Kumuda, if she asked one question, her antenatal corticosteroid rates are only 15% in a huge, big 20,000 women who are delivering their preterm. Why 15%? You need to get to root cause by doing a Pareto chart analysis and try to fix one thing or the other so that your antenatal corticosteroid rates increase from 15% to maybe 90% over 4 to 6 weeks. The key to quality improvement learning and methodology is, for the beginner is, first, do a small QI project which will be finished within a period of 6 to 8 weeks and 3 months. Once you know that, you start coaching a team for doing another quality improvement project which is giving you quick result. Then what you can do is gradually you can take complex projects like what Suman Rao at Bangalore has done. The third step in this is developing a PDSA or change idea. And the fourth, which is very crucial, is sustenance of that gain which you made in quality improvement. And what Saurabh asked was, you get something which is good, but it slips back. If you do only tinkering in quality improvement, it is going to slip back. But if you make some system change and get to the root cause, then the sustenance is going to be there for a very, very long time. We have a vibrant website, which is a www.POCQI, P-O-C-Q-I, Point of Care Quality Improvement.org. Here you get all the resources for learning QI. There is a self-learning mode also of POCQI. You click it, it takes you step by step that you learn the POCQI methodology, 4-step methodology. And at the end, you can generate a self-certificate for yourself. So this is how we are spreading quality improvement skill, which is the part one. The second is, how do you create coaches who can coach the team which do quality improvement work? So at AIMS, as I said, we started working with USAID, started working with all AIMS in the country, centers of excellence, and then moved to a few of the states which I'm going to share with you. We did in West Bengal with their leadership on board, started with medical college and district hospital. We also did a 4-month coaching course through the IHI with the help of USAID support. Many of the people who are sitting here have undergone that course in which they developed their own quality improvement projects which were mentored through the WebEx system. At AIMS, we have a culture. We have a lot of quality improvement, small projects which are sustained for more than 2 years. They are published also and are going to be published more and more in times to come. Here are 3 projects which are shown here. This left one shows how we are able to increase the EBM use in premature babies and sick baby in the NICU, which was very less to begin with, that practically at this point, 90% of premature babies, sick or premature, get only mother's milk. We did some PDSs for that. People who are interested can get to the webcast, which is there on the YouTube by our nurse leader, Meena Joshi. The second one is on increasing kangaroo mother care duration in premature sick babies, even on CPAP. How we increase this from 4 hours to more than 8 hours or 10 hours, and in few babies even to 16 hours. Again, there is an audio-visual podcast to this. And on the right side is how we reduced in VLBW babies who are getting admission to the NICU, the hypothermia incidence. And that was using different PDSA cycles, and this got NNF Gold Medal Award last year, and the presenter were Dr. Sindhu and her team. In West Bengal, we started this in medical colleges, quickly moved to the district hospital, created teams, and then they had success stories which they published, showed us case studies. It went on the media there. And then we also started doing with 3 centers, AIMS, PGI Chandigarh, and GMC, Deepak Chawla is sitting here, a quality improvement project in the SNCUs of Madhya Pradesh. And our primary philosophy is do no harm to the babies. So for doing QI, you need skilled professionals and infrastructure. We in India are committed to provide, universal health care. And each one of us who is sitting here should adopt at least one SNCU. If you have your unit which is doing great, it will give you an opportunity to you and your team to learn a lot of things which you can contribute from back to the society. And as I said, we did this ROP Prevention project, which is need-based, based on what people need there. We started collecting process data on the standardized tablets, and then mentored, and this is on the processes which are there, and then kept on measuring the outcome. Outcome is number of babies who are having laser, number of babies who are having threshold ROP, and how many babies are getting screened in these. So there is an Optha team which is doing that. And teams from 6 SNCUs chose own problems for improvement while we did face-to-face meeting. Following that, weekly web calls were done. Another 3 minutes, sir. And then we coached through the WhatsApp group. They completed 6 QI projects, which they are going to share in the NNF meeting in Gurgaon in the coming months. And we are going to do a collaborative again end of this month. Here is the key. How can you get this done at a bigger scale? On the left-hand side, you see, you have Dr. M.K. Bhan, the most respected pediatrician of the country, sitting next to Vinod Paul. And then next to them is sitting the Chief Secretary. And next is the NHM, National Health Mission Director there. All the CMOs, all the medical college obstetrician and pediatrician, they are sitting in that particular room. And for 5 hours, the leadership is told what we are going to do. And there is a political will. They want to do it. We asked their quality assurance people to come and make presentation. What is existing there in their district hospital and medical colleges? What needs to be done? The chief secretary is sitting there. The senior people are sitting there. They are committed. They want to do it. And then we make a concept framework how this is going to be done. Because we don't want to push our energy, life is short, just on training of people, which gives no dividend. We want something which is substantial, which will make a difference. And then we want them that they have a data system which is collected there, data system which is working. We incorporate our process measures which have to be done and start working. On the right side is West Bengal. The cabinet minister, if anyone is from West Bengal, Tridip Banerjee, he wants to get it done. The UNICEF partner, you see Gagan Gupta sitting on the right side, they want to do it. Vinod Paul is sitting there. NHM director is Sangmitra Ghosh sitting here. So they want to do. There is a buying in by the leadership and the bureaucracy and a political will. Then only is a point in doing quality improvement and spending your energy there. Unless there is this, it is very hard to have a gainful quality improvement. So our learnings are from AIMS, which is a large hospital. My director is on board. We have local champions across disciplines, and it is ownership of team. They don't stop after doing one QI work. We have regular meetings where they make presentation. Multiple projects they do. West Bengal model I already shared. Madhya Pradesh I already shared, where we are working for ROP. And in the ROP project, we have inbuilt into how we are going to use competency-based teaching learning and new pedagogy for simulation for teaching doctors and nurses there by making a hub and spoke model in the medical college there, where the nurses and doctors will go for simulation-based teaching learning in addition to learning premature baby package. Himachal Pradesh, I said, is already. So for doing a sustained QI, you need to learn the QI skill. You need to know how the coaching is going to be done. You need to have a structure and a system in place, and then it has to become a culture in that particular hospital.
Excuse me?
I'm done, sir. I'm done. Last slide. Institutional commitment, top leadership is often required because you need system change. You need local person. Frequent learning sessions are important for taking QI. We need to educate our bureaucrats and politicians that there is a distinction between quality assurance and quality improvement. This is the biggest hurdle I have come across in the last 3 years. They think QA is there, no need for doing QI. They don't understand what is the difference between QA and QI. And then, as I said, process data need to be there in the data system, which is there getting collected in the country. Lack of teamwork culture. Because as students in our schools, we are not taught how a good team can be made. So most of the old professors, they don't want to have any change. So that is, again, a great barrier to quality improvement. So I think I said what I wanted to say, Indian perspective, and if we have to take it to spread and scale in any of the state, These tenets, which are so important, need to be first in place, and then we can have local people, local champions, whose capacity and capability of doing QI our team can build, and you can take it forward. Thank you so much.
Thank you, sir. That was an excellent presentation. And I think we share all your the challenges which you have said. The problem between QA and QI is really very important across the whole country. So what I really wanted to understand from you is, like, as you are aware, we are doing the Safe Care Saving Lives program, and currently we are working in 54 facilities across Andhra Pradesh and Telangana for improving quality of care. The question which always comes is that how do you really define success in QI? Because the Safe Care Saving Lives project started with the aim of actually reducing neonatal mortality by 15% over a 4-year period through quality improvement, and we've really struggled doing that. Though we have had multiple successes in terms of improving processes, what we are really finding difficult is that we've really been not able to show the link to the outcome of reducing neonatal mortality.
So to me, whenever you do quality improvement project, to begin with, your aim should not be very over-ambitious. To have a dent on mortality is going to take a lot of time. You need to do a lot of improvement in a lot of processes which may be there in healthcare facilities till the time you will get that dividend of reducing the mortality. Even doing quality improvement project which improve and show you that the processes are improving, after some time, if they add up, your mortality certainly is going to come down. So I would say, to begin with, do projects which are simple, doable, feasible, quick turnabout time, do 1, 2, 3, 4, 5, 6, and then once you have enough number of people who are very committed to do it, then you can frame large projects. I know from program point of view, that is what donors want, that suddenly everything should improve, but it takes huge, big effort for reaching that goal.